So today we'll talk about the diffusing capacity of dust-exposed workers. Okay, these are my sources of support. I don't think there's any conflicts in terms of the lecture that I'm going to talk about today. So what I'd like to talk a little bit about is to first just put the diffusing capacity for dust-exposed workers in the context of the ways that we prevent occupational lung disease. And the examples I'll use are going to be coal miners who are exposed to coal mine dust and are at risk for developing black lung disease, but really it can apply to dust-exposed workers who are exposed to artificial stone dust or other kinds of stone dust or construction workers. But this example is the one that I use because we have so much data on these workers that we were able to really take a good look at it. So we'll talk a little bit about the DLCO, the diffusion capacity for the lung, at first, just to review how it works. And then we'll talk about how that's used in evaluating impairment. And then we'll look at the role of cardiopulmonary exercise testing in evaluating impairment and how the DLCO predicts people's exercise capacity and their exercise gas exchange problems. And then maybe a few recommendations for the surveillance of workers who are healthy, and then also for disability evaluations for mineral dust exposed workers. So just to review for all of you, I'm sure you all know this very well, but primary prevention really means reducing overexposure to, in this case, coal mine dust, but whatever the toxin is in the workplace. Secondary prevention is really where we live, and in our group and in many occupational medicine programs, where we're screening and evaluating workers who are asymptomatic, but who have exposures and are at risk for developing disease. And if we can identify early disease, then we can make the choice of advising them to reduce their exposures or mitigate their exposures, or possibly remove them from exposures. And the main things that we do for occupational lung disease, the most common surveillance tests are chest imaging. And to this day, it still is mainly plain chest radiography, digital radiography, that is, and lung function testing, although there's a fair amount of effort to move this to low dose CT scanning as a method of surveillance, but that really hasn't quite achieved its day in the sun. And for lung function testing, that's the other method, and it really has been mainly spirometry. And then tertiary prevention is where all of us who are clinicians working in hospitals and clinics really are, where we are diagnosing people who are symptomatic. We're treating them, we're rehabilitating them, and then we often assist them for compensation. And some of the tests that we use for surveillance of asymptomatic workers, we also use for disability evaluations. So we'll talk about coworkers at first, and just to mention the efforts at primary prevention and the way that we get all this data that we're now able to analyze for coworkers, really, as is many things in occupational medicine, it's a result of a disaster. And the Farmington coal mine explosion in West Virginia, in Farmington, West Virginia, killed 78 workers. It was the first nationally televised disaster, and it led to the Coal Mine Health and Safety Act of 1969, not just because of the disaster, but because of the activism of workers. Miners actually marched on Washington and got Richard Nixon to sign this bill into law. And so as a result of that, they established permissible exposure limits for respirable dust. They outlined a national respiratory screening program for this workforce throughout the United States, and a removal program if somebody had disease that they could, if they showed up with disease, and in this case, it was just early disease on chest radiography, they could be transferred to a low dust job and have job protection. And then it also established NIOSH, Appalachian Research Laboratory, which became the group that I work for, the NIOSH Respiratory Health Division, to be able to do research and improve the health and safety in mines. Just a quick word on primary prevention, because we've been working really hard using our surveillance data to advocate for better protections for workers in the primary prevention of these diseases. So the standard from the passage of the Act until 2016 was a 2 milligram per meter cube time-weighted average for respirable coal mine dust. But in 2016, that was reduced to 1.5 milligrams, and the ways that it's measured and the accuracy in which it's measured and the comprehensiveness was improved. And then permissible exposure limits for respirable crystalline silica have also been improved. In 2014, OSHA finally, after decades of people advocating, reduced the exposure from 100 micrograms per meter cubed for workers exposed to respirable crystalline silica down to 50. But it took until this past April for the Mine Safety Health Administration to do the same thing for miners, sand and gravel workers, and stone workers. And that was finally passed in April of this year. So we now have the same standard. And then they also improved monitoring and enforcement for MSHA inspectors, OSHA inspectors, and requirements for employers to sample to make sure that these levels were not exceeded to prevent the disease in their workforce. But they also mandated improved surveillance, surveillance with chest x-rays and surveillance with lung function. So we'll talk now about medical surveillance for these dust-exposed workers. And since 2016, OSHA mandated that workers exposed to more than 25 micrograms, what they called an action level for respirable crystalline silica, should be provided with a chest x-ray and a ILO classification. That's the International Labor Office classification of the x-ray, done by a NIOSH certified B reader, who are those physicians that are certified to do this. And offer spirometry as the lung function test. So again, it's imaging and physiology. MSHA has done this, required this for respirable coal mine dust. Since the passage of the act, they only required X-ray, but in 2014, they did add lung function. They had a little brief program on their mobile unit for spirometry in 2005, but now since 2014, it's mandated that all these workers who are exposed to respirable coal mine dust get offered evaluations and screening with chest x-ray and with spirometry. And then finally, they extended that in April of this year for all these sand and gravel workers and stone pit quarry workers. MSHA extended the surveillance requirements, the same ones that had been used for coal miners since 2014. 10 years later, they finally enacted it for these workers who are in sand and gravel. And actually, it's a much larger workforce that work in those areas than work in coal mining these days. One of the sad things in my mind is that surveillance data is not required to be centrally sent to NIOSH for analysis and research, unlike the coal data, which is required to be sent to NIOSH. So we're hoping that that'll change and that we can then get a handle on that data so we can do research and evaluate how this population is faring. The respiratory screening program for the coal workers is probably one of the largest and best surveillance programs for a workforce in the United States because it is a federal program and it does really work very well to help us identify and prevent lung disease in this population. And then it provides that information back to the miners. So one of the problems, though, is that these programs of medical surveillance, they use chest x-ray, which is not a very sensitive tool. And Dr. De La Hoz can share with you his work in CT scanning for these populations of exposed workers and let you know that CT scanning is much more sensitive, but it, until recently, has been very, very expensive and more radiation, although that has improved. So spirometry just evaluates the bellows function of the lungs, how big the lungs are, how big your vital capacity is, and how quickly air goes in and out of your lungs. So it can tell you whether there's obstruction or restriction, but it does not evaluate the gas exchanging surface of the lung, and therefore it can fail to detect early interstitial lung disease and early emphysema. And both of these diseases, early interstitial lung disease is another pneumoconiosis is an interstitial lung disease, and that may not be detected until somebody really has significant restriction or damage to their lungs that their spirometry goes below the lower limit of normal, which is quite a wide range. And it isn't at all useful really in detecting emphysema until someone develops obstruction. So the DLCO is a test that has been used for many decades in pulmonary medicine for taking care of patients that are clinically presenting with interstitial lung disease. It's a really important predictor of gas exchange abnormalities with exercise, and I'll show you from the work that we just did recently on how helpful that can be. So as a resting pulmonary function test, it is the only test that we can really do that's an indicator of gas exchange. which is really the primary function of the lungs, to measure the ability to transfer oxygen from the alveolar space into the bloodstream and combine with hemoglobin to be carried to the tissues. So it really measures the integrity of alveolar capillary units. And it can detect pulmonary vascular disease, which would not be detected by spirometry or conventional lung function testing. And we've had cases where we found tumors involving the pulmonary vasculature that have been identified through this modality. So what is the diffusion capacity and what are the determinants of how does it work? So the first thing we have to do is we get a test gas that contains carbon monoxide, and it has to travel through the large airways, the small airways. It has to be mixed in the respiratory bronchioles and gas exchanging surface of the lung. And then the gas has to transfer across the alveolar membrane. And if the alveolar membrane is damaged, if it's thickened, if it's scarred, or if these units are gone, then the diffusion capacity will be reduced. Then it has to transfer across the capillary membranes and capillary plasma into the red blood cell, where it reacts and binds with hemoglobin relatively irreversibly for the purposes of this test, and then it's taken out of the pulmonary circulation. So you can see the test gas goes into the alveolus, crosses the alveolar capillary membrane, the capillary membrane into the capillary where it's bound to hemoglobin and then removed from the lungs. And it's really important because people that have scarred or thickened membranes may not show significant problems with their gas exchange until they are exercising or until the pulmonary capillary transit time is reduced. So normally, if you're a run-of-the-mill average RBC and you're spending time in the pulmonary capillary and the patient is at rest, it's about 3/4 of a second or 1 second that the blood cell spends in the pulmonary capillary. When you exercise, you reduce that time, and people that are exercising very, very rapidly will have very high heart rates, and the transit time falls to less than 1/4 of a second. So you can see that your PCO2 will be normal even if you have abnormal diffusion, as long as you're at rest. But it falls pretty quickly as you exercise, and the same is true for PO2, and we'll show a slide about that. And for normal people, they don't really see any problem until they're exercising very, very rapidly, and that's why people can do heavy exertion if they have a normal alveolar capillary membrane. And this is the same graph for PO2. So you can see if you are normal, it really takes very, very heavy exercise before your PO2 will drop with exercise. So extremely elite athletes might have a decline in their PO2 because they can get that RBC transit time down to a very, very low level. And you won't detect it if you have diffusion impairment at rest. So many of our pneumoconiosis patients or workers, if you just test their PO2 or their blood gases at rest, you won't detect anything wrong. And that's why the diffusion test, which measures this and can detect an abnormal diffusion curve, is so important as a resting test. The test is done. It's a fairly simple test with relatively simple nowadays equipment. When I first started doing lung function testing in the late 80s of the previous century, it was pretty complex, clunky equipment that was certainly not portable and couldn't be used in the field, but that's changed quite a bit. The patient takes a vital capacity breath from a reservoir that contains the test gas. It contains 0.3% carbon monoxide and 10% of an inert gas, either helium. Some people use methane. The concentration is really 0.003, is very low because we don't want to kill our patients. We just want to test the ability to transfer this test gas and see how well the patient's gas exchange is. They hold their breath for 10 seconds, then they exhale and we analyze the sample. And this is a curve that just shows that maneuver. It's not a very hard maneuver, but the patient has to be able to hold their breath for 10 seconds. So someone who's quite short of breath really can't do this test. But if you can hold your breath for 10 seconds, then it is a test that most people can do. They exhale all the way to residual volume. They take a deep breath all the way into total lung capacity of that test gas. They hold their breath for that 10 seconds, and then they exhale, and the sample is taken. This is a washout volume, which is really the dead space of your large airways until you get to alveolar gas. And this is called the alveolar plateau, and we measure how much carbon monoxide is left in the sample at the end of that breath. If you have really good diffusion capacity, you'll be able to transfer a lot of carbon monoxide from the airspace into your bloodstream, and you'll exhale less carbon monoxide, meaning you have a great diffusion capacity. If your lungs are scarred and fibrotic, you can hold your breath, but very little carbon monoxide will be transferred from the alveolar space into the bloodstream, and then you'll exhale much more carbon dioxide. You'll have a very low diffusion capacity. And this is the way the test works. They have a reservoir that has the test gas. The patient inhales it, holds their breath for 10 seconds. They exhale, the dead space is discarded, and the alveolar sample is analyzed. The analyzers are pretty straightforward. Most devices have a spirometer so they can measure how much is inhaled, make sure you've got a good breath that's inhaled. And then it has a CO analyzer and a helium or methane analyzer. This is a device that's made by one company that just shows you. It's called the Easy One Pro by a manufacturer that makes these really small devices, and it's very, very portable. The only thing that you have to take with you are the tanks of the test gas, but it can be done in the field. And NIOSH Field Services Branch and many other organizations are now trying to add diffusion testing to their field work and not just spirometry. And just to show you, this is the diagram from the ATS and European Respiratory Society schematic for interpreting lung function testing. And you can see the top part really just looks at spirometry. There is a bit here on lung volumes, but to really figure out what somebody has, you really need diffusion testing to distinguish between pulmonary vascular disease, chest wall and neuromuscular disease, interstitial lung disease, and to tell the difference between asthma and chronic bronchitis and emphysema. So the diffusion test really adds a huge dimension to our ability to understand patterns of impairment, more than just simple spirometry, which tells you how the lungs are getting air in and out, and the total lung capacity, which really just tells you how big the lungs are. So let's go now to talk a little bit about some of the work that we did. And there's two articles that I'll talk about that were based on the same large data set. The first is both from our group. My colleague, Dr. Leonard Goh, is the first author on this paper, which was looking at the resting predictive value of the lung diffusing capacity and talking about its work in surveillance and disability evaluation. And the second paper that I'll talk about is the one that I'm the first author on, which is looking at the predictive value of diffusing capacity for exercise gas exchange and whether or not somebody might be disabled with exercise. So these are really companion articles. And if you want to really be fully up on this, you can get both of them and take a look at them. So we had the opportunity. The data comes from a really interesting data set. There was a lung doctor who worked in West Virginia from the late 70s until 2015 and did probably, maybe 50,000 or 60,000 exams on coal miners in Appalachia, in southern West Virginia, southwestern Virginia, Kentucky, Tennessee. They would all come to his laboratory. He was an amazing physiologist. Dr. Donald Rasmussen is his name. And he kept very careful, standardized, computerized records of history, physical exam, the results, very, very structured. And they also had computerized physiology data. And he exercised people and studied them very, very systematically with a very straightforward protocol. He passed away in 2016 in his estate, and before he passed away, gave us access to all of this data, which we have been analyzing since that time to understand the physiology of Black lung disease in this population. So that data set, which was his work from 2015 back to 2005, had over 8,000 exams on about 5,500 individual miners. And the objectives of this first study was to characterize the abnormalities in the diffusing capacity for the lung among these former coal miners, and to evaluate the association between diffusion impairment, spirometry results, and the presence of and severity of disease on chest radiographs. You may know that pneumoconiosis is often divided into two major descriptions. One is simple pneumoconiosis, and the other is complicated pneumoconiosis or progressive massive fibrosis. And it used to be thought that simple pneumoconiosis, which means that the scars on the lungs were smaller or were up to 1 centimeter in diameter, wasn't really associated with physiologic impairment. But only when you had progressive massive fibrosis or when you had complicated pneumoconiosis did you have disease. And we wanted to look at that and see if these lung function studies really showed that there was nothing, no significant impairment for simple pneumoconiosis compared to the complicated pneumoconiosis. So we looked at people that had complete data. So it was about 3,000 for this cohort. We looked at their occupational history, smoking status, their chest radiographs, which were really their ILO classifications for pneumoconiosis. We looked at their spirometry and diffusion lung capacity measurements. And then we evaluated the factors that were associated with declines in the percent predicted of the diffusion capacity. And this is a photo of Dr. Rasmussen towards the end of his life in his clinic in West Virginia. So we found that there was a significant prevalence in this population of miners, mostly at the end of their careers, who had diffusion impairment. So 20%, 1 out of 5, had significant diffusion impairment. But of great interest was that 10% of the miners that had normal spirometry had diffusion impairment, including about 7.4% of never smokers. So if your program is only going to be looking at spirometry and it's not going to be looking at measures of gas exchange in the lungs, you're going to miss a substantial percentage, 20% of subjects with significant impairment that will not show up on spirometry alone. And then if people thought that it was only smoking that was the result of that, the fact that 7.4% of never smokers had disease was really an important finding also. And as you may know, silica exposure and coal mine dust are both associated with emphysema and can cause obstructive lung disease with a potency that's probably equally potent to that of tobacco smoke exposure. The other thing that we saw as an overview, and I'll go into some of this data, was that diffusion impairment worsened as the profusion of scars on X-rays worsened. So let's just take a look at this. This is looking at profusion category of coal miners and then what their spirometry and diffusion capacity showed. So first is category of no coal workers pneumoconiosis. So they had X-rays that were normal. And then we have been advocating to change the terminology for pneumoconiosis from simple CWP, which makes it seem like it's no big deal, to just using the term small opacity pneumoconiosis. And you'll see that in the articles that we've been publishing. And I think that there's general agreement in the medical community to not use the term simple pneumoconiosis anymore, because it sort of gives people the wrong impression that the disease is not important or it's quite simple, nothing to worry about. So small opacity, previously known as simple pneumoconiosis, and then the worst form of the disease, progressive massive fibrosis, where people have scars on their lungs that are bigger than 1 centimeter in their long axis diameter. And you can see that in this population, 30% of people had abnormal FEV1s, less than the lower limit of normal. When they developed small opacity disease, it went up to 36%. And then people that had, in addition to that, had large opacity disease, had 50% of them had an abnormal FEV1. And then the percentage of those folks that had moderate to severe disease was less, but it still tracked with worsening perfusion on the X-ray. They had worsening, a greater number of folks that had moderate to severe reductions in FEV1 from 11 to 16%, and then to nearly 30% of those with progressive massive fibrosis. And then in DLCO, there was also a dramatic increase. And you can see that this increase for DLCO was more than double those with no disease. So if you had normal chest X-ray, 12% or 12.6 overall had a diffusion capacity that was less than the lower limit of normal, but more than double when they had small opacity disease, and then up to 40% when they had progressive massive fibrosis. And then the same pattern of more than double, almost 3 times the number of people that had small opacity disease had abnormal diffusion compared to those with normal chest X-rays. But just to mention again that the normal chest X-rays doesn't mean that you don't have impairment. And this was an important finding that the diffusion capacity certainly adds important information to our understanding of impairment in these mineral dust exposed workers. And then looking at this data with never smokers, just to show that it's not all smoking. When we get miners or workers that come in with lung disease that have been exposed to mineral dust, sometimes their employers will assert that it's all due to their smoking and that these dusts are really not that dangerous. But in fact, never smoking miners also had the same pattern of impairment with normal X-rays, small opacity, and then larger opacity disease, moderate to severe disease tracked as well. Diffusion impairment was a more dramatic change again compared to the smaller changes that we saw with FEV1s, where they went from just about a little less than 5% of people had abnormal diffusions with normal X-rays, and then more than triple that when they had small opacity disease, and then a higher percentage when they had progressive massive fibrosis. And then again, you can see that moderate to severe diffusion was not that common in people that had normal X-rays over in never smokers, but that number was more than five times higher in people with small opacity disease, and then increased again with PMF, although these numbers were smaller. And then for people that had normal spirometry, we just took out all those folks that had normal spirometry just to identify what diffusion capacity adds to the evaluation of workers beyond spirometry. And we saw that 10% of all workers with normal spirometry had abnormal diffusion, 5% of workers with no disease, 15% of workers with simple, and 30% with PMF who had normal spirometry had these abnormal diffusion values. And moderate to severe impairment, which would be close to what we would consider disabling impairment for the heavy labor of coal mine work, also had these significant changes. And we can see that overall 3% of people had moderate to severe diffusion impairment with normal in all categories of chest X-ray who had normal spirometry, and those numbers were smaller but still significant, and therefore we think important to get diffusion capacity. And then the numbers for never smoking miners with normal spirometry still had significant impairment, significant percentages of people, which also increased by their X-ray radiographs. Again, and that was quite a significant difference, showing that the dust disease causes damage to the gas exchanging surface of the lung in people absent smoking and with normal spirometry. And these folks would all be missed if you, in terms of their impairment, if you didn't have the diffusion numbers. And for moderate to severe disease, the numbers were smaller, but still important. Sorry. And this is just a graph of looking only at the small opacities, taking out PMF, of the percent predicted diffusion capacity by the small opacity profusion. The ILO profusion scores are a little bit complicated to understand, but it's a 12-point scale. This is just taking out the very lowest scale of completely normal. And you can see that the percent predicted declines in a nice linear fashion as you have an increasing category of small opacity profusion. So I think that this really shows you that small opacity disease, or what they used to call simple pneumoconiosis, really isn't so simple and is associated, as one might imagine, if you have more profuse scars on your lungs, it would likely be associated with worsening physiology, worsening disease. So to summarize that study, we had a decrease in diffusion with small opacity profusion. 10% of never smokers had diffusion impairment. And the significant predictors of decreased DLCO included small opacity profusion, having large opacities. I didn't show the data for this, but years of coal mine employment, as you might imagine, were a predictor. So that's our kind of crude tenure variable, and then pack years in smoking. And then this is the article that Dr. De La Hoz circulated, which just takes this to the next level, which is looking at diffusion capacity and gas exchange abnormalities with exercise. Because really one of the important things in evaluating a worker is, can they do the heavy labor of their work? So they may be okay as a pulmonologist or as a physician in clinic, but they may not be able to shovel coal for 8 hours a day or do heavy manual labor. And so this is Dr. Rasmussen in his laboratory. And let's see if I can get rid of the pointer. Okay. And this just shows you how the exercise tests are done. Miners have an internal and arterial line. They're measuring.
Hang in there.
They're measuring gas exchange at peak exercise. So you can see that if you're going to do an exercise test correctly and you're going to measure gas exchange, you can't do it really with single stick arterial blood gases. You have to put in an arterial line, and right at peak exercise, when that person can't breathe very much anymore, that's when you want to get the arterial blood gas. And it's quite difficult to do it any other way. So this is how he did these thousands and thousands of miners in his laboratory with a very standardized protocol. So the reason we did this is that if you're trying to evaluate workers, sometimes people can't perform maximal exercise tests. They may have cardiac limitations or neuromuscular disease or arthritis and can't do it. And so we need to get better predictors for exercise gas exchange abnormalities. So what we thought we would do in this study was take that data from Dr. Rasmussen's laboratory and then try to establish the relationship between diffusing capacity, which is the same test that we talked about before, again, radiographic disease, but this time looking at exercise variables and radiographic disease, and then cardiopulmonary exercise test abnormalities. And look at the potential of using the diffusion capacity as a predictor of exercise-induced gas exchange impairment. And of note, the federal government pays for black lung evaluations for workers who have worked in the mining industry to be evaluated for black lung disability. But they only pay for spirometry. They don't pay for diffusion testing. And so that was one of the reasons, is that we've been really advocating for the Department of Labor to add diffusion testing to their tests that they will actually pay for in the evaluation of coal miners. So in this case, there were fewer miners that were able to undergo exercise testing for the reasons that we mentioned. They had contraindications, cardiac or neuromuscular are the most common. Sometimes they were uncontrolled hypertension. And so we wanted to look at this population, but that's still a lot of exercise tests. I don't know how many exercise tests are done in your division at Mount Sinai, but we do maybe just 2 or 3 a week, and it's really hard to get these huge numbers that Dr. Rasmussen did. And we had the same demographic information. We had their resting lung function tests, and then the cardiopulmonary exercise tests with arterial blood gas measurements. But I would say that cardiopulmonary exercise testing is a wonderful test to do if there are no contraindications, to truly evaluate the work capacity of somebody that you're trying to determine whether they're fit to go back to work or if they're disabled. And this is just another picture of Dr. Rasmussen's laboratory. So we measured the standard pulmonary function test that we talked about before. And let's see if I can get my pointer back. And then we measured cardiopulmonary exercise testing variables. This tends to be an alphabet soup of all kinds of measures, and my pulmonary fellows' eyes glaze over when we start trying to teach cardiopulmonary exercise testing and how to interpret it. But the most important ones for you to remember are just their VO2 max, their oxygen consumption at peak exercise, their alveolar arterial oxygen gradient. That's a measure of their PO2 corrected for their PCO2 pretty much. And then their dead space, how much of the lung is really scarred and not participating in gas exchange. And we measure that as a ratio to their tidal volume. The population had a mean age of about 62 years. Their coal mining tenure was substantial. These folks had nearly 30 years of coal mine employment. 33% were never smokers, and the average smoking for the people that had smoked was about 25 pack years, so relatively modest. And I would mention that coal miners as an occupation in general are not able to smoke as much as other workers. Back in the day, your plumbers and your carpenters could smoke while they were working. If you're underground in a coal mine and you smoke, you will blow up. So most coal miners don't generally smoke while they're on the job. And then 47%, which is a pretty high percentage, did have abnormal chest radiographs consistent with coal workers' pneumoconiosis, but over half did not. And so we looked at the population overall just to see what were the abnormalities that were detected in cardiopulmonary exercise testing. 32% of them had an abnormal AA gradient, which we defined as greater than 150% of reference. The wider, the larger your AA gradient, the sicker you are, because that's how the AA gradient calculation works. If you remember that from your MICU rotations or your other rotations. 20%, so a third of them had abnormal gas exchange in that respect. 20% of them had an elevated dead space, which means that more than 1/3 of your tidal volume was dead space. And that's a measure that we get at peak exercise. These are all peak exercise measures because that's the measurement that we want to use to compare and evaluate whether or not you can do heavy labor. What is your gas exchange like when you're working hard? What is your dead space like when you're working really hard? And what is your maximum work capacity? And 34%, about a third, had a VO2 max that was less than 60% of reference. And I use that number of 60% because that's the number that the US Department of Labor says if you are less than 60% of reference, you are considered disabled for heavy manual labor. And that's just a guideline, but that's probably reasonable to use for workers that are working in any occupation. If they have to do heavy manual labor, it's likely that 60% or less maximum is not compatible with that. And certainly you can't, and that was just 60% for a very short time at peak exercise. Most people who do heavy manual labor do it for several hours a day, and you can't sustain your peak, really no more than 30% or 40% of your peak for 8 hours. And then it goes up a little bit if you only have to do it for briefer periods of the day. So this is just an evaluation, a similar graph to the graph from our other paper, looking at the relationship between these gas exchange abnormalities at peak exercise and the category of radiographic disease. And again, what we wanted to show here is that simple CWP is not simple. It's really a progressive interstitial lung disease. And you can see that the AA gradient at rest, at peak exercise, was abnormal in 1 out of 5 people that had normal chest X-rays. So this is important also because, and also in relation to the other paper, people would think that if you don't have pneumoconiosis on chest X-ray, if you don't have scars, you can't have a dust-related lung disease. And that's not true. These dusts, silica and coal mine dust, cause emphysema. They cause chronic bronchitis and lung function impairment, even absent scarring on the X-ray. So you can develop scars as one manifestation of your dust-related lung disease, or you can develop emphysema and COPD. And these folks with normal chest X-rays are those that have a coal mine dust lung disease, we call it, or a mineral dust lung disease without the scarring, at least without scarring seen on plain chest radiography. It'd be great to take a look at their CTs and see what they might have. Then if we look at their prevalence, and so, I'm sorry, so the prevalence doubled when they had small opacity disease and then increased still further if they had large opacity disease. And these numbers are fairly substantial that we're able to get hundreds of minors in these study breakdown groups. There are dead space abnormalities. This part of the lung that's scarred and doesn't participate in gas exchange was present in 15% of normals, 23 or 24% in people with small opacity disease, and then about the same actually for the PMF in this case. And then the prevalence of having a disabling PO2 was really quite significant in people with normal X-rays and small opacity disease, and then with PMF. Of interest, we looked at the DOL's criteria, the Department of Labor's criteria for a disabling PO2. And that's really based on a certain PO2 for a certain PCO2. And then if you look at our paper, we give you the exact criteria for that. But you can see that 10% of people with normal chest X-rays had a disabling PO2 on exercise. And so that's really why it's so important to exercise people to determine their disability, because you'd miss 10% of disabled workers if all you did was look at their chest X-rays. And then that went up quite substantially if they had small opacity disease, nearly 3 times as much. And then again, still further when they had large opacity disease. And then for never smokers, the data was also important, again, trying to make the point that these diseases are dust related as well. And that if you have people that smoked and had dust, it's important to note that they have an additive or additive effect. It's not quite multiplicative or super additive, but it's an additive effect. And their A gradient was abnormal in people with normal chest X-rays, non-smokers, 1/3 with small opacity disease, and 2/3 with PMF. Also, their dead space increased with increasing disease on chest X-ray. Their VO2 max didn't change quite as much. And this is a little bit softer variable because people stop exercising sometimes, not just for physiologic reasons, but they may stop exercising for if they're uncomfortable or for other reasons. So these were not just people with maximal tests, but it was all comers. And then we can see the disabling PO2 in never smoking minors was abnormal in 4% of people with normal X-rays, and then triple that for small opacity disease, and then 1/3 of minors with PMF had disabling PO2s. And then we just took one look at, we did a multivariable logistic regression of the predictor variables for that disabling PO2 for all study subjects, just to show you the predictive value of these resting PFT findings. And I just wanted to compare for your benefit spirometry, FEV1, which is the most important measure of impairment from resting lung function, versus DLCO. And for a 10 unit decline in percent predicted, you can see the odds ratio for having a disabling PO2 was 2.33 compared to 1.18. They're both significant, and spirometry is obviously an important variable. But I think that DLCO is a stronger predictor from resting lung function for a disabling PO2 with exercise. And again, that's one of the things that we're really trying to emphasize with the U.S. Department of Labor as to why it's so important that they pay for and provide diffusion testing. And that's one of the things that we have not yet added to the surveillance program for coal miners in the United States. It's really just spirometry and lung function testing, but we really think that, and it would also apply to silica exposed workers. We really think that diffusion testing, so simple now, so easy and so portable, should be, and so important, should be added. And just to show you the predicted values.
Robert, can I
Yes.
ask a question just
Yeah,
before on
please.
the previous slide, just because it was pending from even previous one? Did you do any analysis where you did FEV1 or the LCO? You see what I mean? Is
Separate.
well,
We
because you know,
yeah.
I'll tell you why. Because you're doing them together, right? So why did you
Mhm.
find either or? What are, the calculations as to, because you could detect also coal dust lung disease, which is also the name that you have advocated correctly for this disease, right?
Yes.
Could cause also airway disorders, right? We know that, and that the
Mhm.
respiratory bronchioles are actually the first target. So there could be FEV1 and or DLCO abnormality, and I don't know if you did any of those analysis in the background or plan to do.
Yeah, we did do it. I don't remember what the odds ratios were. We did this together just to see, but that's a great. I'll go back and look at that,
That
Rafael,
would
and
be
see
very
what
interesting. I
that
would be
shows.
very
Yeah.
interested. Yeah.
But
Okay.
actually, the disease that you're talking about is really important. Mineral dust small airways disease.
Absolutely.
Those respiratory bronchioles it's a very important finding.
And the
And
X-ray
many
would be
people,
normal. Many of those people
exactly
with
right.
normal chest X-ray may have that. You
Exactly right. And that would not show up on anything else. And that's where the oscillometry that you're mentioning, or had mentioned before we started talking, would be an interesting thing as well, to take a look at that. But thank you for that question. That's really great. And then this just shows you the odds ratios for having abnormal diffusion, abnormal gas exchange, disabling with each category of disease. And so for every small category from 0, 0 to 0, 1 to 1, 0 and so forth, it was a substantial increase in disabling gas exchange. And then as you got bigger categories of scars, as you might expect, the gas exchange worsened. And then this is just a graph of the same thing of looking without the PMF, the increase in AA gradient with small opacities that were just, you can see a nice linear increase or maybe not so nice, and then increase in the dead space VDVT at peak exercise with and diffusion percent reference. So again, just making this point that simple pneumoconiosis is not so simple. So our conclusions from this is that diffusion impairment is common, as we saw from the previous study, even in those without smoking history or without radiographic evidence of disease. It provides significant additional insight into lung function that spirometry alone cannot, and it can be used to detect early chronic lung disease when spirometry and radiographs are normal. So I think I've made this point. I probably pounded it to death, but I think that it's important that we use a small opacity as our term. Diffusion is a strong predictor of exercise gas exchange abnormalities. It should be included in black lung evaluations and medical surveillance of mineral dust exposed workers. And I'm sure that you're all familiar now with the artificial stone workers who have horrendous silicosis. That population, I think, would really benefit from very careful medical surveillance, including diffusion testing, and that small opacity CWP is associated with significant physiologic abnormalities, and we should revise that term or not use that term.